Hello, welcome friends, and welcome to this Facebook Live. On the occasion of the World Cancer Day, we are here to discuss a very important topic, and that's regards to childhood cancers. As we know, the theme for the next 3 years is going to be Close the Gap. And the first year of this, as a part of this theme, it's going to be how to identify the barriers of cancer care and how to identify the barriers which lead to suboptimal care and outcomes in cancer. Now, we're going to be discussing today an important cancer type, that is the cancer in children. And as we all know, this is one of the subjects which is probably the least talked about when we talk about cancers at large. So I'm here today with my colleagues. My name is Dr. Sunil Bhatt. I am the head of the Paediatric Hematology and Oncology at the Majumdar Shah Cancer Center in Narayana Health, Bangalore. And I've got three colleagues with me today. Dr. Shobha Badigar, who is a senior consultant with me at the Majumdar Shah Cancer Center. She along with other two colleagues are dealing with the childhood cancers day in and day out. I have got Dr. Pooja Malia here, who is along with Dr. Ravi Joshi, also working in our department as a pediatric oncologist. So thank you very much, Dr. Shobha, Dr. Pooja, and Ravi for sharing your valuable time with us today. A very important subject, that is childhood cancers. And as I said earlier, I think this is one of the cancer types which is less talked about. And because this session is for the common public, and we would try to answer and discuss some of the very common questions which come in our mind, and this in the same session try to raise some awareness about the childhood cancer. So first question to you, Dr. Shobha, is that a very common question which comes from the parents also who we deal with is that they had never heard that cancers can come in children as well. So what's your thoughts on that? How common are pediatric cancers or childhood cancers?
Pediatric cancers are not as common as other common conditions. If you want a figure, it would be somewhere like 50 to 150 per million general children population every year. If you want a rough comparison, the other common condition in the public is tuberculosis. So if you compare with tuberculosis, every 100 children, around 5 to 6 children are diagnosed with TB every year. When compared to that, cancer is very less. The number of cancer diagnoses in children is very less. Again, compared to adults also, cancer diagnosis in children is less. Around 5 to 6% of the entire cancer diagnosis is constitutes of pediatric cancers, children cancers.
So it's not a very common condition as you are mentioning, but at the same time, as we are trying to conquer and control other diseases, especially infectious diseases, non-communicable or non-infectious disease like cancer is something which is a significant entity, and as you said, 5 to 10% of the cancers overall are affecting children less than 18 years of age. Now, Dr. Pooja, what basically comes to our mind is that we know about adult cancers, breast cancers, colon cancer, mouth and head and neck cancers, which are very common, but we don't see these kind of cancers in children. So, if you could tell us briefly that what are the type of cancers we see in children, and how are these cancers different from cancers in adults at the same time?
So as you mentioned, definitely the spectrum of cancers which are seen in children are different than adults. So as you said, breast cancer, colon cancer is not seen. The most common cancers seen in children are, number one would be leukemias, which in layman term is just blood cancer. That's a cancer which is arising in the bone marrow and the blood. And this comprises the majority of the patients which we see, which would be around 30%. In that, we have acute myeloblastic leukemia and acute lymphoblastic leukemia, and rarely we have chronic myeloid leukemias. But in that, commonly we see ALL. The second would be brain tumors, which we see very commonly in younger age group. And then thirdly, we have lymphomas and other solid tumors. So lymphomas are the small swellings of glands which are called lymph nodes in the body. And the other solid tumors which are commonly seen in pediatrics are, you can have neuroblastomas, which are tumors arising in nerve cells, or you have an eye tumor like retinoblastomas, or a bone tumor which is commonly seen. But yeah, the spectrum of the diseases seen in pediatrics are different than adults. that would be fine.
So I think the what you mentioned was, if I summarize, is that the cancers in children are different from
Different,
adult
yes, sir.
cancers, and at the same time, the locations of cancers are also different. So we do have a little bit of different profile, and one of the important things which you mentioned was second common cancer in children is brain tumors, which is something which a lot of people still fail to understand. But yes, that is something which is important. After blood cancers, brain tumors are the second commonest cause of cancer. Now, Dr. Ravi, when you see these children, in your practice, and when you also have these families which are, we always say that childhood cancer doesn't affect the children, it affects the families, because you got parents, grandparents, and extended families involved with the care of the child, and it kind of is a life-changing event for the whole family, and of course, puts a lot of anxiety and worry on the whole family as such. So, a very important question which comes is that what has led to this cancer, or in other words, what has caused this cancer in the child? So, if you could tell us what is the cause of cancer in child, and also sometimes parents tell us that did they do something differently in the upbringing of the child, which has led to this cancer diagnosis in their family. So, what would you comment on that?
Yes, sir. In fact, unlike as others have covered, these cancers are a little different from adult cancers, pediatric cancers.
Yeah.
And most of the times, you can say that we will not be able to identify the exact cause why the cancer has occurred. It is neither related to their upbringing, or neither related to their food or water intake, or the family history as such. Most of the times, we will not come to know the exact cause. There are few cancers in the pediatrics, probably constitutes around 5% to 10%, where we can identify that there is a syndromic baby initially. Then they will present later with some blood cancers or some other solid tumors. Otherwise, there will not be any cause as such in pediatric cancers.
So it's very important to understand that childhood cancers are not lifestyle cancers. Adults are lifestyle cancers. Cigarette smoking, alcohol, high fatty diet, lack of exercise, some of the factors, chewing tobacco, some of the factors which lead to cancers in adults. But in children, most of the cancers, as Dr. Ravi just mentioned, 95% of them will not have any identifiable cause. It's just a random phenomena which happens in children. And a very small percentage may have a genetic cause, or what we call a syndromic cause. So they may have some underlying genetic disease like Down syndrome, for example, and they may have a little bit of higher incidence of developing some kind of cancers. But overall, it has nothing to do with the upbringing, nothing to do with the lifestyle. It is just a random phenomenon which has just happened in the child. Now, as I said, it's very difficult for families to accept. Even from the medical community point of view, I think childhood cancers are still considered to be extremely rare, and we hardly think about them when we practice in general population. So, Dr. Shobha, what are the some of the alarming signs, or what we call as the danger signs, which you would probably brief our audience, what the doctors or the families which can identify and seek medical attention to see whether there's a child is having some kind of malignancy or cancer.
So those pointers that point towards cancer depends upon the type of cancer. That is the first thing we need to remember.
Yeah.
So in general, any child with unexplained fever, when I say unexplained fever, all the common conditions like viral infection, bacterial infection, these should have been ruled out. So unexplained fever, despite adequate treatment with antibiotics and all the necessary tests, and if there are any repeated infections, and also if there are red spots on the skin, which we call it in medical terms petechiae. So these are bleeds in the skin because of low platelet count. So these are kind of pointers in a child that this may be a blood cancer. In addition to that, if the child also has vague body aches, joint pains, and the child resists carrying because of pain. So this also kind of in combination with fever and these bleeding spots in the skin or in the gums can point towards cancer. And again, depending on the cancer, if the child has headache, unexplained headache, vomiting, and a little bit of change in behavior, sleeping a lot, very irritable, This can point towards brain
Brain tumor is
tumor.
a possibility.
And if they see any mass anywhere in the body, maybe in the neck, maybe in some part of the body, limbs, or on the thighs, on the leg, or swelling in the eye, all these are in general they should be unexplained. You find a painless mass anywhere in the body should also point towards cancer. So it's a very vague thing, very difficult to identify at the initial stage. But keeping these symptoms in mind, ruling out other conditions, we should have a high index of suspicion for cancer.
Yeah, so I think what you mentioned is very important, and one point I think you made is that lumps and bumps in the body, and especially these lumps and bumps are painless. So it's a myth, I would say, that cancers are painful. So it's in fact the other way around. Usually the swellings or the lumps and bumps which are in the body, which come because of malignancy or cancer, are usually painless swelling. So if you have a painless swelling without any identified cause, and all the other symptoms which you just mentioned, we need to seek an appointment and need advice from the doctors to figure out what is happening. Now, Dr. Pooja, once a suspicion has been made and there's a suspicion there may be malignancy in a particular child. So what would the next approach be? What would be the diagnostic workup, and what are the next step you think we should be taking to rule out or diagnose a child with cancer?
Once a child has certain symptoms where if even the pediatrician is suspecting a pediatric cancer, it's always better to refer to a pediatric oncologist, because they'll be more familiar with working up with these children. So it depends on the type of cancer we are going to suspect. So suppose if we are suspecting a blood cancer, we would do a basic blood checkup, which is called a complete blood count. We would like to see the 3 parameters, which are basically the hemoglobin, which is the red cell, and the white blood cells, as well as the platelets. So that would give us an idea whether there's something wrong with the child. So sometimes you can have low hemoglobin, which is anemia, or low platelet count, which is called thrombocytopenia, and your WBC count can either be very high or very low. And we can even ask the pathologist to see if there's something wrong in those cells, which can give us an idea whether the child is actually having a blood cancer. If we are suspecting that, then we would like to do a bone marrow exam. Now, I know most of the parents are very scared with the first word of mentioning a bone marrow exam, and most of the times for children, it is done with so that they are very comfortable, and most of the times these children are put to sleep, and this is only for a very short time. And for pain also, we are giving them good medications. So we take we put a small needle in the backbone, and we just take a little bit of blood and send it for testing. The next would be if we have brain tumors, if we are suspecting that, we would have to image the child. That means we would have to do either an MRI or a CT to know where the tumor is and whether it has spread anywhere else. If we are suspecting of lymphomas or any other solid tumors, we'll have to find out the exact location of the tumor. We should have an idea what type it would be and whether it is spread anywhere else. So depends on the location, we might have to even do a biopsy of that. So suppose we have a lump in the abdomen and we are suspecting it could be any of the other solid tumors, we would like to take a small piece from there and send it for testing.
So it's very important, as I said, to have an appropriate diagnosis and what we call is also staging of cancer. And these days, a lot of advances have happened the last decade or so. So it's no longer important only to know what type of cancer we're dealing with. It's also important to know what we call as what category or what biological category of cancer we're dealing with. So all the 3 things are important. So this diagnostic workup may involve a bone marrow examination, may involve some imaging, CT scan, MRI, and a biopsy, probably to know what actually we are dealing with. Now, Dr. Ravi, a very important question is now that, okay, we have diagnosed childhood cancer, and the cancers, as we all know, is like a death warrant, especially in our country, because I think we still are of a belief that cancers are universally fatal. There is probably no treatment for cancers, or even if we treat it, they can be controlled for some time. But I know it's a myth, because you'll explain us in the next few minutes that why it's a myth. And so I want you to basically touch upon what are the treatments available for treating cancer, and what are the expectations out of this treatment, because that's important for the families and the caregivers to know, who put a lot of effort and time and money for getting their children treated. What actually is the outcome expected if we treat these cancers?
Yes, in fact, it's an important question. In fact, everyone should know that pediatric cancers are entirely different from adult cancers. In the kids, for example, if we take an example of blood cancer, as we have discussed earlier, acute lymphoblastic leukemia, you can take an example. The treatment will be initially giving some injections that we call it chemotherapy. After initial evaluation, after initial all the investigation, we'll start the child on chemotherapy, some injections for initial few months. And I should like to I would like to stress upon that most of the times, say we consider some 85 to 90% of the times, the leukemia will get cured. This acute lymphoblastic leukemia will get cured. Only 10 to 15% of the times, children will get the disease back. We call it a relapse. Even for that relapse also, most of the times, say some 50 to 60% of the times, we can give some other chemotherapy, and then the child can recover from that. That's why pediatrics in that way, it's a great, pediatric oncology is a great branch where can save up to 85 to 90% of the kids with ALL. In fact, whenever we say the word chemotherapy, again parents will start asking us what are the side effects to the child, immediate side effects and also the long-term side effects. Unlike adults, kids tolerate chemotherapy very well. In fact, kids most of the times will not have any comorbidities like adult people, and these cancers respond very well to chemotherapy. And the chemotherapy drugs are, and the entire protocol is designed to suit kids, their organ systems, so that the toxicity will also be minimal, and the toxicity, that minimal toxicity can also be managed very well if the child can be treated at a comprehensive center where child's nutrition is taken care, child's side effects are taken care, where we have other super specialty facilities, for example, pediatric intensive care, pediatric gastroenterology, endocrine. As a team, we work here, and comprehensively, if we treat, most of the times outcomes are very good in pediatric cancer.
So, friends, this is one of the very important messages we want to communicate, convey in the first half of our discussion today, and that is childhood cancer, although not very common, but is an entity which we need to know of. It is something which we need to be suspicious, and we have discussed what symptoms, if they are in the child, we need to look for and consult a pediatrician first, and maybe oncologist to look at if the malignancy is there in the child. Now, very important point we wanted to make out here is that most of the childhood cancers can be cured, and we are using the word cure. Cure means cure forever. And as Dr. Ravi just mentioned, 70 to 75% of the people can be cured forever. For the children, can be cured forever. Although there may be some recurrences or what we call relapses in some children, but that also can be treated the next time. But however, having said that, of course, it's a hard work for the child, for the family, and for the treating physician. So the message number one is that childhood cancer is not a death warrant. It's something which can be dealt with, and majority of the children can be cured and can have a healthy long life. Now, going to the second aspect of our discussion, Dr. Shobha, and that is what Dr. Ravi mentioned is that chemotherapy forms the backbone of treatment for childhood cancers, and of course surgery will be required in a substantial number. Radiation, probably very small percentage of children. Chemotherapy especially comes with a lot of anxiety from the family and the parents, because they worry that chemotherapy is going to be something very, very dangerous and something very, very painful. So I just wanted to ask you that what would you want to share with the families of the audience listening to us, that what is chemotherapy? What are the side effects of chemotherapy, first of all? Very briefly, we don't need to get the details, because every chemotherapy will have different side effects. And more importantly, is chemotherapy painful?
So first, I would like to answer the second question, whether chemotherapy is painful. So chemotherapy is a special terminology. So the terminology is what scares the patients and the family. So it is a term based on how the mechanism of action of the drugs. But that's it. It ends there. Otherwise, the way the chemotherapy is given is just like any other antibiotic or intravenous fluid. So it is the chemotherapy as such, giving the chemotherapy as such is not painful. And because the children will require these injections repeatedly, sometimes it may be twice a week, sometimes it may be once in 3 weeks, we don't want to keep pricking the child every now and then. So we have what is called central line placement. Central line placement is something like a cannula that you use for the routine injections with a longer tube, and it is placed in certain places of the body, like either in the arm or in the chest, in such a way that it enters a big vein. So you can do, we do blood tests from the same tube and also give drugs through the same tube without pricking the child. So pricking is not a problem in children who are on chemotherapy. So if parents are concerned that every now and then we'll be poking the kid here, there, and it's going to be painful, no, that's not the case. We use the central lines, and therefore pricking is very minimal, kept to a minimal. And while giving the chemotherapy also, it is not painful. It is like any other drug. The colors may be different. Sometimes it is dark red, sometimes it is yellow, and sometimes it is clear fluid. Apart from that, there is no problem while giving the medicine as such. As far as the side effects are concerned, parents are always worried about two things. One, the immediate side effect, and the long-term side effect. The immediate side effects are common but easily manageable, and most of the times, not most of the times, almost always, children get medicines to prevent these immediate side effects, and they are vomiting and a nausea feeling of vomiting but not able to vomit, and child might feel loss of appetite, not able to eat properly, they don't like the food or the smell of food, and general weakness. Child might want to sleep most of the times, but these are all easily manageable, and unlike adults, children do really well. In fact, I would call it like a magical thing. The moment we start treating, almost all the symptoms that we just described, disappears within a few days, and the child is playful, interactive, starts gaining weight, starts eating. So I would say not to worry about the side effects, especially the immediate side effects. The other immediate side effect that is quite concerning for parents, especially if the child is older, is the hair fall. So the chemotherapy has this side effect of causing hair fall of almost all the parts of the body, the scalp, the eyebrows, eyelid. But this is a very temporary side effect. Once the chemotherapy is stopped, or the intensity of the chemotherapy reduces as per the protocol depending on the cancer, the hair growth happens naturally and would be just like how the child is destined to have the hair growth. So this is another side effect. As far as long-term side effects are concerned, there are a few long-term side effects. It might affect the heart and cognition and other things, but these are very few, and most of the drugs are given in such a way that these side effects don't happen. So we tailor for each child depending on their body surface area. We reduce the drug dose in such a way that they don't get these long-term side effects. Extremely rare is a second cancer, which is so rare that I wouldn't consider that as a main deciding factor for the treatment of the child.
Thank you very much. That was very elaborate, Dr. Shobha. So what I think we understand is that, of course, treatment of cancer does come at with a cost, and the cost is of going through the treatment of the cancer, which we just discussed, will be chemotherapy, surgery, radiation, and those treatments, of course, are given for the benefit of the kid, to get them cured of the disease, cured of the cancer, but at the same time will have some long-term, short-term side effects which the child and the family, of course, will have to go through. Now there will be some modification in the lifestyle, Dr. Pooja, and there will be deviation from the normal when you are dealing with cancer diagnosis in the family with the child. So what the families have to modify and have to adapt to this new lifestyle, of course temporary for some time till the treatment is going on. So what in brief, if you could just, not the specifics of it, but for the for families maybe who are listening us and who may have a childhood cancer diagnosis at home, so what are those which you want to tell them? What are the modifications in the lifestyle and the way they have to look after themselves and the child during that time?
The modifications during treatment are going to be only during that period of treatment. So it's not going to be lifelong. That's very important because most of the people think that the child is going to be under the threat of cancer throughout and will be requiring treatment for the rest of their life, which is not true. During that period where the child needs to get better to lead a healthy life in the future, there are few things which are very important, especially for a child. One would be that the child cannot go out. The child would have to be isolated, in the sense the child would have to take treatment in the hospital and then go back home. We would have to keep the child away from relatives as well as other children, which is a little bit difficult because once you get the diagnosis of cancer, you'll have so many people who would want to come with a good intention to help the family, who would be worried about the child and would want to come and see the child. But because the child can have a detrimental effect because of people who are unwell or people who are coming and touching the child, simply it would be a difficult part for that child. So it's better to keep the child at home, which is a little bit difficult. We'll have to try to engage them in activities at home and when required come to hospital. The next would be the child will not be able to attend school. This is only because these children are immunocompromised and they will be at high risk of infections. But this does not stop the child from not doing the school activities. Now with the COVID era, we even have online classes which are going on, as well as the parents can get involved with the child. We have certain institutions which come and teach the children in the hospital itself. That is one thing. The other would be that the child would have to restrict his diet, in the sense he can eat whatever he wants or she wants as long as it is home cooked. Outside food, in the sense which is packaged, which has a good expiry date and which are from good brands, as well as homemade food is what is important for these children. And at this age group where children want to eat everything possible, including ice creams plus outside food, this is a little bit of a problem. But I think most of the children get used to what we are going to tell them, and we also have a dietitian or a nutritionist with us who tries to explain the parents how they can make food more presentable and try to, whatever food they're going to cook, they'll try to make it more tastier, and whatever the child wants from outside can be tried to be made at home. These are the main things which the child would have to give up, but that is for a temporary period of time.
I think we forgot to mention that the childhood cancer treatments usually last weeks to months, and if I have to give a number, average treatment will last for 6 to 8 months, and that's a substantial period of time. And during this, what Dr. Pooja was trying to say is that because these children are on chemotherapy and other treatments which compromise their immune system, and we make sure during this time that they are not at excessive risk of infections from outside or from the environment, and that's what modification she just mentioned. Number two is, of course, it is we always advisable to be in contact with the local or your treating teams and be closer to the hospital as much as possible. And number three is that compliance, I think, is very important, which we also need to mention, is that compliance to the treatment, because it's hard and tough times, and there are many instances during a treatment you lose heart and you lose hope, but I think that's very important that we keep the momentum on, we keep going with our treatment plan as per the advice of the oncologist, because these are tough times, rainy days, and there will definitely be a sunshine at the other end of this time duration. So that was a very important message as well. Dr. Ravi, we're social animals, and we live with our families within our society and our community. And we have come across this many times that either the family members themselves are worried that one child has got cancer, it may be transmitted or it may be infectious to the other child in the family. A lot of people I've heard and also come across is that the families and relatives stop talking to them or interacting with them because they are worried that this cancer can be contagious and it can come and infect their children or their family members. So I think, would you be able to convey a message here that is childhood cancer contagious, is basically the question.
In fact, cancer is not contagious. That I should tell you all. And the second thing is, as you said, sir, we are all social animals. Here in this period of time, 6 to 8 months or 1 year, the society, the family, society, and the entire hospital staff, they have to support the family well, so that the child will recover and he will lead a normal life later.
A very important point. I think it's also other way around that we, in fact, rather than boycotting this family and the child, it's our responsibility as extended family, as caregivers, to come forward and support this family during this time, which is, of course, a testing and hard few months to go through. Now, Dr. Shobha, we discuss this very often in adult cancers, and that is, how can we, is there any way we can prevent? And that's also one of the questions which families will ask you, that could I have prevented this anyhow? What do you think on childhood cancers? Is there any prevention strategies which can be adopted?
So, since we don't know the cause of pediatric cancer, it's not easy to prevent the cancer. Most of the cancers you cannot predict.
Yeah.
So, because you cannot predict, prevention is a little difficult. But there are a few cancers that can easily be prevented. For example, eye tumor, which is called retinoblastoma. So, if there is a family history of any cancer, especially at a younger age, less than 60 years, you have a family member who has suffered from cancer or who has died or who's been cured of cancer, then that's a flag that you have to be alert. And if the child has any, there can be a family screening. Especially for some tumors like retinoblastoma, which is an eye tumor. There is a schedule in which the child will be called to screen eye examination to find out if there is a early onset cancer. But I wouldn't call it prevention, but you can diagnose it at an early stage. There are certain syndromes like what you said, Dr. Sunil, Down syndrome and Fanconi syndrome. These children with these syndromes are more vulnerable to cancer. So such parents can educate themselves and know what are the signs and symptoms and come for an early diagnosis. So I would rather call it early diagnosis than prevention methods, because we don't know what are the foods and what are the things that can cause cancer, and these are not proven to cause cancer. It's very difficult to tell X and XYZ are the actions that you have to take to prevent cancer.
Yeah, so that's a very important point we want to discuss, because we know in adult practice or adult cancer world, there is definitely preventive strategies, because most of the adult cancer, as we discussed earlier, are lifestyle cancer. So cigarette smoking leads to few cancers. Excess alcohol leads to few cancers. So if we have preventive strategies around them, of course, we're going to be preventing cancers in adults. But unfortunately, children, because the cancers are just a random phenomena without any identified lifestyle cause, we do not have any preventive strategies. But what we have is what is called as early diagnosis or early detection, because it's very important. If we diagnose these cancers early, in children as well, the outcomes are going to be better. And as Dr. V was mentioning, it can be in the range of 90-95% also in some of the cancers where early diagnosis happens. So, how to detect early is that to have our routine pediatric checkups when they are young, and pediatricians also be aware of what they should be looking at these routine checkups, and also families and doctors to be aware of these alarming signs or the danger signs which we mentioned, and so that the families can and a diagnostic workup can be offered. Now we discussed this briefly, Dr. Pooja, and that I want to just spend 1 minute on that, and that is once we have, as I said, the treatment is for a few months. We have finished our treatment, whatever treatment was required for a particular child. The child is cured of cancer now. So what are the long-term consequences of treatment or the cancer itself, or the treatment of the cancer, which we need to know, or what we call as long-term effects of cancer, which we need to know and also be aware of in the years to come?
So there are two things which we are looking at. One is the side effects of the treatment we have given, which can have long-term effects, because these are children who are going to then become an adult. And the next would be the chance of the cancer coming back. So these are two things. So one is because of the treatment, which could be either the chemotherapy or the radiation, and very rarely sometimes with surgery. So we could have certain organ damages which can happen. But for this, what we do is, it is important to have a proper follow-up care. So we call these children on follow-ups every 3 or 6 monthly, depending upon the period of the time they have finished from treatment. And we look for these organs, whether they have got affected. And if required, we take necessity action which is required to help them get better from these conditions. So sometimes you can have certain drugs which can affect the heart. You can have certain drugs affecting lungs. Growth can be impaired. Sometimes sometimes if they've received radiation. Fertility can be an issue. We can have even their problems with brain development, in the sense the way their intellectual ability can also get affected. So, but timely pickup as well as timely action on that would be important. The next would be that with the follow-up care, it can be easy to find out whether these cancers are coming back. The chances of that, as Dr. Ravi mentioned, is less, but still we need to have a follow-up on these children. So because even if it comes back, there is still treatment for these children and still a chance that they can get better.
So thank you, Pooja. I think what we're trying to emphasize is that yes, even after the cancer treatment is over, we need to see the children for the effects of the treatment they have received and also effect of the cancer they have had, and that will require initially a little bit more closer follow-up, but even after that, follow-up which probably we can say is lifelong, so that we make sure that if there's any long-term side effect that can be identified early and can be addressed early, because we can sometimes, and most of the times, probably fix it if it's identified early. Now, before we conclude, Dr. Ravi, this is my last basically question, and that is, as I said earlier, that this year the theme is close the gap, and closing of the gap will be only possible when we identify what were the problems we are facing. So, what in your understanding is the probably are the barriers of cancer care in children in India? I know there are multiple factors which determine it, and what are the common ones, or what are the most important ones which you think are important? And of course, when we acknowledge them, then only we can address them and close this gap.
Yes, sir. In fact, diagnosis of picking up signs and symptoms at the earlier stage at peripheries, in fact, we'll have to do a lot of awareness programs. Mainly pediatricians. Most of the times, children will tend to go to, parents will take them to a pediatricians for some cause. For example, as
so first would be the awareness of child cancer is not there much
yes,
in India, so
yes.
we need to make people aware of that.
Okay,
that's one.
And then diagnosis at the earliest, for example, as you mentioned earlier, we'll have to do a simple test called CBC, peripheral smears and bone marrows, just to diagnose it earlier.
So availability of diagnostic facilities
And referral to the centers who are comprehensively treating pediatric cancers. That will be the third one. Fourth one, as you mentioned earlier, compliance to treatment, because it's a short treatment, 6 to 8 months. If they do it completely, 100%, if they take treatment, most of the times, 80 to 90% of the times, child will get cured.
Yeah.
And follow-up for growth and other side effects of chemotherapy, that will have to do it.
And we have also, I think, added problems, which is abandonment in India. So treatment abandonment is a very, very common problem. That means you start treatment, then you don't continue it because for various reasons. Financial aspects are very important. I think these are long treatments. Families sometimes lose their jobs in the process, and they have to move cities, they have to move different places. I think geographical or the travel distances is also one of the concerns, I think, which comes one of the important factors where the parents are not able to continue the treatment. And of course, also the availability of pediatric oncology centers. Not many centers in India have got pediatric oncologists where children can be treated effectively and adequately. So these are some of the barriers, I think, of course, we know of and probably can be addressed to be able to close this gap. So friends, so this was it from us for the on the discussion of the childhood cancers on this International Cancer Day. And what we tried to do was to address some of the myths around childhood cancer. The myth number one was childhood cancer is extremely rare, or it's kind of unknown, but it is not unknown. What we try to say that it is rare, but it's not that rare that it cannot happen, and it is something which we see in quite a few children, and especially the centers which are treating children with cancers. It's one of the major problems to deal with. Second myth which we try to address was that unlike adult cancers, these childhood cancers are not life-set cancers and they do not have an identified cause. And the third was that most of the children can be cured unlike adults, and about 75 to 80% of the children can be cured, especially if they are detected early and treated adequately. They can be cured. And number four, what we also try to address is that, of course, these are life-changing diagnoses, and whole families and the extended families are involved, and it's very important to support the children and the family during this difficult phase, so that they can have their treatment finished. And last but not the least is that even after finishing the treatment, it's very important to keep a follow-up of these children, to identify any long-term side effects which may come across, and so that they can be identified early and dealt with. So thank you very much, Dr. Shobha, Dr. Pooja, and Dr. Ravi, for your valuable time and valuable inputs. And we are available for any more clarification of your questions. So you can get in contact with us, and we'll be very glad to answer any of those questions which may have arisen in your mind. Thank you very much for your attention, and thank you guys. Have a good day.